Welcome to Let's Talk Antigonish, the podcast where we sit down with neighbors, experts, and friends to explore the stories, the questions, and the big little issues that shape life in our town, one conversation at a time. This week, we're talking about palliative care. If you're like me, you probably think you know what it is, but if you're also like me, you are probably wrong. Let's find out. Hello, everyone, and welcome to Let's Talk Antigonish. I am your co-host, Justin, here with
Anuj,
the other co-host. And we didn't use our last names this time. I feel like this is a whole thing at this point.
yes, exactly. I hope people know us by now.
Yeah, of course, we're very famous.
They're better.
So, yeah,
Okay.
they're better. So we are sitting down today to talk about palliative care. And we have two people who are experts in this industry. Emily Rice, a palliative care physician. Hello, Emily.
Hi.
And Jamie Campbell, a palliative care nurse consultant. Hello, Jamie.
Hi.
So you are here today to talk to us about palliative care. Let's start with what on earth is palliative care?
Palliative care, I would say, gets a bad reputation sometimes.
Oh, this is exciting. So it's controversial. So, what is it? Why does it get a bad reputation? This is exciting.
People get confused about what palliative care actually is, and often it's introduced at difficult time in people's lives. And so they're often struggling with lots of other things that are going on, and they think that it means often that they are dying. Or that they are going to die soon, or us being involved means that will happen sooner. And it's true that we get asked to see people who have something serious going on with their health. That's who we get asked to see. And often that serious thing going on with their health means that their time is going to be shorter than it would be if they didn't have that diagnosis.
So someone is like, oh, if I head into palliative, that means this is the end, and they're going to hasten my death? Is that what you think
There is some confusion sometimes
Okay.
between palliative care, and now in Canada we do have medical assistance in dying, so there is confusion between that, and often people think it's a place as well. I have to go to palliative care, and that's not the case either.
So palliative can be at home.
Palliative care is a way of caring for people. It's the approach to care, which means that it's really important for the care provider to get to know the person, what's important to them, and how do we consider that despite everything that's going on with their health? How do we make sure that their quality of life is good even though they have a serious diagnosis?
Okay, so this is good because you are right that I misunderstood what palliative was. You're already clearing up things. So if someone is near end of life, they would call palliative. But what you're saying is also they could be diagnosed with just a chronic condition and still call palliative? Or what is the criteria for being accepted in
So,
palliative?
for example, why would I come to palliative care and not an emergency department of the health?
Right.
Now you've asked lots of questions.
Yeah, it's so many questions. Yeah.
We really don't know.
Yeah. So what I would say is that palliative care isn't a specific team. It isn't a specific place. It isn't a specific thing. So palliative care is best delivered by the people who know you the most. So ideally your family doctor or the specialist that's been involved in your chronic condition for a long time. So it isn't necessary to have a specialized team to even provide palliative care. It is the approach to care and what is considered in terms of what's happening to you within the medical system and psychosocially and community supports. It's really big picture of how do you get the best support possible despite something serious going on with your health. And we are part of a specialized team that is kind of what we would consider like a consultant level. So when those people who know you best are involved with your care and there's something complex going on that they're not able to manage with, their expertise in palliative care, because every physician does have training in palliative care to some degree, then they would refer to us. If your family doctor needs support in managing what's going on, then they would refer to us.
Okay, so your family doctor will be offering palliative care. Is a social worker also someone? Like you're saying
Yes.
so anyone involved in your care at all, even a family member, involved in palliative, kind of? Or does it have to be a clinician of some kind?
Family members are super important parts of anybody's care team. And by family member, I mean, that can be your chosen family, right? Whatever that actually means. So yeah, and to be honest, family members provide like 95% of the care that people need, right? We pop in, the people that are designated within the medical system pop in and out of somebody's care, but it's really community and family members that are mostly involved in people's care in the community. So yes, but the approach to care and the way that palliative care is delivered, What I tell people is this. Sometimes the concept is hard to understand. I tell people that if I was going to build a house, not actually going to build a house.
Fair enough.
I need a contractor, but people talk that way, right? They
Yeah.
say, I'm going to build a house. But really, the contractor is there to tell you what you need to make sure the house is what you want. It's really important for you to communicate what's important to you. Do you want a little cottage by the lake? Do you want a 3-car garage? What is it that you want? If you don't communicate what's important to you, the contractor is going to get it wrong, right? And then they're going to tell you, what do we need to get there? What kind of electrical system? What kind of, support beams? I don't know. I'm not a contractor. But when it comes to your healthcare, I am. So it's really important for people to talk to us about what's important to them. And then it's our job to say, okay, how does that fit into what's important to you? Because people don't always understand when they come into a hospital. There's a lot of things we can do to them and for them, but that doesn't always meet their goals. And that ultimately is what palliative care is about.
I see. So you function like a contractor in that you're navigating the medical system together with whomever is brought you on board.
Exactly. And that's different for each person, right? You can have the same diagnosis, be the same age, maybe on paper look very similar to somebody else, but what's important to you is very different than this other person. And your treatment plan and how we approach that should be individualized to you because your goals are not necessarily the same as somebody else's.
I guess just to take your analogy, I go to a contractor and honestly, I don't know.
Exactly.
Right? And so I defer to that expert saying, you tell me what to do. And I'm likely not to be prepared mentally for that stage of palliative care. So how do you navigate that conversation with the family or with the patient where they don't know what they don't know?
I usually tell people kind of what I started with, and it's very rare that somebody says no, that they're not interested in support. But, if they do, that's okay. We're not there to step on anybody's toes. And if they're not ready for us to be involved with their care, then that's fine too. So I say, you've been diagnosed with something serious. We're not here to be the oncologist or to be your hematologist or, whatever other physician is involved in. They're still going to be managing whatever it is as long as they can. But we're here to say what's important to you, to get to know you well, and try and make sure that you have the information that you need to make decisions that are good for you within the healthcare system, as well as help manage symptoms and your quality of life moving forward. People don't say no to that.
No, that sounds nice, actually. But so clarify for me who then is getting called in for palliative. I'm still unclear. Do you have to have a specific kind of diagnosis in order for palliative to be called in?
So some of this is a bit of a resource availability situation, which is why, the physicians, the medical team that knows you best has a lot of ability to kind of start those conversations. What are your goals? How aggressive do you want your medical care to be? What supports do you need in the community? But if things get more complicated beyond that, then those providers would refer to a palliative care team. The evidence is that early palliative care is best in both acute and chronic medical conditions that are life-limiting in whatever way. So generally, people who have palliative care approach, palliative care team involvement live longer than people who don't, which, most people don't know that either. But here in Antigonish, we mostly see people who have about a 6-month prognosis or less, just in terms of a resource management standpoint.
Very useful to know.
Because I'm thinking of lots of conditions which could fall under an umbrella of life limiting.
Exactly.
And ALS, for example, that was my mother died of. I do not recall palliative being involved at any stage of that because that's essentially when you get the diagnosis, maybe 3 to 5 years maximum. So that's kind of a prolonged thing. But I would have imagined palliative would have been very helpful for us, but it didn't get called in. So are there conditions, is the 6-month a hard and fast rule?
No.
Okay.
Not at all.
So it could be someone with a 3 to 4 year
and sometimes
disease.
there's stages of illness. So sometimes we will come in and work with the primary care team, whether that is a family physician or, for example, like a multidisciplinary ALS team, and say, okay, there's something going on from a symptom management standpoint or a community support standpoint that we can get involved with. And then, okay, you're okay with your team for a while, we will sign off and then can come back in. So occasionally we do get involved and we have conversations about those situations. So physicians talk to each other a lot, teams talk to each other a lot. Hey, I have this patient, this is going on. Do you think there's anything you can offer to support? And we kind of say, yeah, we could, or you actually probably better left with this person. So
break this down for us. Say, and you do have a center here with some facilities, additional facilities in addition to the health system.
yes.
So break this down. What can an Antigonisher expect, and how does one access palliative care? What does it mean? Look like?
So I would say that, when we're talking about diagnoses that are life-threatening, we tend to group them as cancer and non-cancer.
Okay.
So somebody who has a cancer diagnosis is usually being followed by the oncology team. Here in Antigonish, we have access to oncologists who are outside, and we have GPOs, which are family physicians that have extra oncology training that see people in face-to-face. And oftentimes they are managing that whole kind of approach. Palliative care can exist at the same time that you're getting active treatment for something. So it's kind of happening at the same time. Those physicians are managing symptoms, having conversations about, is this treatment helping meet your goals or not? That's all going on at the same time. And depending on each person's individual situation, they might be referred at a different point in their trajectory back to us, or the family physician might know that patient very well and decide to continue to do home visits even when the oncology team has said, your treatments with us are done. So it's not always a specific way to come to us. But in that situation, let's say the oncologist is following, treatments are not going well anymore, disease is progressing, they're starting to come to the end of the line of, chemotherapies, radiation, immunotherapies, that kind of thing. That physician team would send us a referral and say, okay, this is the situation. Can you please get involved? We are no longer the most appropriate people to be providing care. We are not going to provide further care within our area, but they still need care. Can you help manage that? And that can be in hospital, it can be at home, or people can come see us in the office. So we're often in those spaces in the same day.
Okay, but you do have a physical location. Is that a consulting office, or are those beds?
St. Martha's, I think almost every regional hospital in the province right now has a small palliative care unit. So there are 6 designated beds at St. Martha's for palliative care. That is a combination of people who need to come in for symptom management. So sometimes something's going on at home that you just can't get under control, and you need to come in for some more focused management of symptoms. And once that's done, they go back home.
Okay.
And other people, it means coming in for the end-of-life care. We don't have hospice beds in Antigonish, which is different from palliative care.
So unpack that. What is the difference?
Yeah, so a hospice really is, it's trying to make your end-of-life care as close to possible as at home.
Okay.
But for some reason, home isn't possible. And usually it means the amount of care that you need and availability of
and
family
probably
to do
pain
that.
management and discomfort management and all
We
that.
can do that at home. We do a really good job of doing that at home if people want that and have the community resources to support that, because we don't have 24-hour nursing available in home, and sometimes that's just not manageable for patients and families.
Short question just in between, sorry to inject. So a family, for example, is having a relative or an elder one facing that situation and is simply finding it very hard to manage for whatever reason. Either they are physically not here, overseas, or in different parts of the province. And do you face that challenge as to they even though there might be possibility of them being taken care of at home, simply that is not practical for them, and they get pushed on to the palliative care or hospice care kind of situation?
I don't know that I would say pushed. I think we don't have any expectations that families are going to be able to provide any care. I think the communication and the support is this is the support that's available. This is how we can help. If that works and is doable, then great. But if not, the palliative care unit is always there. We can never, 6 beds is sometimes not enough. We can never guarantee somebody that it's going to be a palliative care unit bed, but the hospital in St. Martha's is always there.
Is also part of
even before we had these designated beds, St. Martha's has always provided excellent end-of-life care. And so that can happen in hospital if somebody needs it too.
So when someone is in one of those beds, you then become the sort of primary contact physician? No,
No.
you're still coordinating other people.
Yes,
Okay.
because our team really does work as kind of this specialty consultant team for cases that need that extra level of support. And because of that, we are seeing people at home. We are having people come in to see us in office, but we are seeing people in hospital too. So we kind of act as this longitudinal checking in several times a week to make sure that things are okay. In complex cases, we will see daily, but in hospital, our hospitalist colleagues or our everyday hospital colleagues would be rounding on those patients primarily, and in the community, the family doctor is still highly involved.
Do you function then a bit like an advocate for the patient within the system? Is that how you would qualify it? Or
We definitely do advocacy work, lots of advocacy work, and lots of access to resources. So just making sure that people are connected with the supports that are available in the community. And then we provide expertise around medication management and difficult conversations. I would say that's one thing that in palliative care we kind of pride ourselves on, is being able to approach situations that are really hard to talk about and trying to help people make sense of those.
So how did you get into this?
Yeah.
And Jamie, please jump in. And is this very hard for you people, daily dealing with it every day? Or, tell us a little bit more about yourselves.
I would say that doing this role, I've gotten to learn that it's quite a privilege to do the role. We get to know patients quite well because we follow them for a period of time. So it's not just, previously I had done other nursing work where we would meet them on the floor, whether or not it was for your set that week or if it was just for that day when they were in for a procedure or needing something. So in this role, we get to follow them and kind of carry through with them and make sure that their care is followed through on. So it's quite a privilege to get to know the patients, but also their family and their support people. So that makes it much easier. Yeah, we're very lucky.
The way that the program in Antigonish from a consultant level is designed is our nursing staff carry most of the day-to-day load. So we cover a huge geographic area as a program that's based out of St. Martha's. So we cover straight Richmond Hospital, Guysborough, Canso, and Sherbrooke, in addition to St. Martha's.
That's huge.
And everybody who's at home in those catchment areas as well. And we're just 2 physician positions. So there's 4 of us that share the equivalent of 2 full-time physicians. So we are not able, and that's one of the reasons that we have we rely on our primary care colleagues and other colleagues to provide that kind of basic palliative care level. But our nurse consultants are here at St. Martha's and based out of all of those community hospitals, and they are the day-to-day contact for our patients and families, and they are following, and we really trust them and their assessments of the situation. They get to know patients and families really well, and then they pull in the physicians when they find that there's an issue going on.
Share some of the insights you have gained in your work in this specialized area, and dealing with the subject itself. I assume is not always easy. So give us insights as what can you share?
It feels good to help people. I mean, I think most people feel that way. There's a lot of personal satisfaction and self-identity that comes from that ability to really help somebody, especially at really difficult times. There's some days that are hard, but overall, I would say I feel like as a team, kind of looking at Jamie there, who's nodding. She's quiet, but important part of the team. We do a lot of supporting each other, but we get a lot out of our work. People let us into their homes, into their lives. They share with us, at really difficult times. And in general, people are like pretty amazing, what they're able to handle in their lives. And as Jamie said, like it really does feel like quite a privilege to be able to provide care for people like this.
So you make a great case as to why this is a rewarding specialty, but I can't say it's a very common one. I haven't heard a lot of people who go to med school who think, I'm going to end up in palliative. So what is your journey out of your degree into this specialty?
And also as RN,
Yeah.
why would you choose this line?
Yeah, how did you end up here? Or were you both always, you say you worked a bit on the floor in other areas, but like you were drawn to this. So we know why it's rewarding now, but before you got into it, how and why did you think to get into it?
I think life happens. I grew up in a small town village in Badak. My mom worked at the nursing home. We always were there. I don't remember the first funeral or wake that I went to. It was just part of our community. So it's never been an area that I've felt uncomfortable with. So in my family and life, it was talked about. I think right now, day to day, we don't talk about death and dying and that normal part of life that is going to affect every single one of us very often. But for me, it was something that I wasn't uncomfortable with. But I would say that in my medical training, those key memories of, those few situations that have stuck with you have been around end of life care. Very specifically, third-year medical student, I don't know anybody who's had anybody train. You feel like you know nothing at that point in time. You feel pretty inadequate most days.
Yeah.
And there was a patient that I was caring for that was really struggling and had, a difficult life story in addition to a difficult diagnosis, and had some children, teenage children, that they had just reconnected with and passed away quite suddenly, even though they knew that they had a significant diagnosis in hospital. And that family had come in the next morning, and the teenage daughter was there. It was her 16th birthday. She had just lost her parent. I'd never met her before. And when I walked into the room, she stood up, walked across the room and hugged me and said, "My mom told me about you. She told me that you made her feel safe." And as a third-year medical student who really didn't feel that I was providing very much, that moment was really powerful in terms of, the impact that you can make in somebody's life, by just listening and helping to do what you can in a difficult situation.
That's a logical origin story for, because that's a very powerful moment. And I could see how that drove everything that happened afterwards. Did you have something similar along these lines?
So like we said, our team works like as a specialty-based team, but palliative care is everywhere in our practice. So working on the floors, I had some experience with palliative care, and actually our clinical nurse leader now, when she did the role that I'm in, I remember her coming down to see patients that I had at the time, and coming down and knowing their story, and coming down and being able to advocate for them without even having to open their chart, and knowing what was important to them. And that made quite an impact on me as a new nurse, seeing that, these patients were advocated for, that they were known, and that there was such extensive conversation had. Because sometimes when you're seeing these patients in a clinical setting, your time with them is so limited. So that was something that had stood out to me. So when I had the opportunity to come work with such a great team.
Fantastic. And we are becoming somewhat culturally diverse in Antigonish and the region. Are you seeing that in your practice? How are you, if at all, responding to that? Share a little bit more about that. People who often don't understand our Canadian health system well enough. Not that Canadians do, but
Sure.
That's a good point.
But are there things that you are seeing that especially newcomers would like to hear?
I think that our team has when we meet somebody, really, we don't have a specific goal other than what are your goals and getting to know you. So yeah, I would say that, historically in Antigonish, things are changing in terms of, how does somebody's healthcare goals fit with who they are in their community, their culture, their religion, their whole worldview of things. And our goal is to fit into that. And so I think just as people may have who have grown up here don't have an idea about what palliative care approach to care can provide, we're willing to kind of meet people where they're at. I ask people often, we talk about a lot of things, but one of the questions I ask them is, what do I need to know about you to be able to take good care of you? And my hope is that opens the door to them saying, okay, I can share. Okay, it's okay to tell, this team what's going on. The other thing is that we know that people accept different degrees of risk and choice in their life. And so we're not a team that's going to tell you that you have to stop doing something or that you have to do something. It's really about making sure that you have the information that you need to make good decisions for yourself.
Do you end up having to navigate a lot of questions that are more sort of practical, like, as we're getting into this stage, you should think about like medical power of attorney or like will and testament? Do you get those sorts of questions, or do you get questions that are like spiritual in nature, where people want to sit and talk?
Or both?
Do you handle
Yes,
those?
to all of the above.
So you get lots of those questions. I assume that's sort of outside of what you're supposed to be doing, or is that really part of it as well?
I mean, we love being able to have time to spend and talk with people. And I think that's often where those connections get made and the trust gets built, right? When you're able to have those conversations with people. But we do have lots of other team members that can help support those conversations. So our nurses, I would say, do get a lot of those questions. And maybe, Jamie, just who else is on our team?
Yeah, so our palliative care team is comprised of our palliative care physicians. We have our palliative care nurse consultants, as well as we also have social workers on our team, which we're very lucky to have. So,
And music therapist.
and our music therapist as well.
Oh, wow.
Yes.
Who does
yeah.
like a lot of that work that we just actually, she does an excellent job with a lot of that work.
Yeah.
She
And
does a
what's her name
wonderful.
again?
This is
McDonald.
Rebecca.
Rebecca.
Yeah,
She's great.
she's wonderful. And so initially, when someone's introduced to our team, they are linked up with one of our nurse consultants and sometimes also with a palliative care physician. And from there, based on patient's needs and what we get to explore with the patient, then we can see, if it's beneficial to bring in social work or music therapy. We do get to have some of these conversations regarding, personal directives and spirituality as well. And we try to kind of, bring in specialties as needed to support that.
Anything around somebody's organ donor, how does those practical matters get?
Yeah, it's we can help address those issues. Yeah, often people who have a serious or chronic illness are limited in what their
Right.
organ donation options are, but we can definitely explore those things with them. And we work regularly with the tissue bank around options that patients, again, it comes up as part of those conversations about what's important to you. And so really, if it comes up, and then we've got ideas that we can go from there.
And how does the Antigonish community get engaged and involved, in supporting, in knowing, in spreading the word, and becoming more educated? Do you have a community angle to it?
We've got some really great community support. So, in terms of our ability to care for people at home in the community, the Antigonish Palliative Care Society is like, I don't know if there's a better organization or fundraising group in town. They're pretty amazing. Yeah, it can be expensive to have end of life at home, and lots of things that we don't think about, right? Like diapers, mouth care kits, buying Ensure or Boost, equipment needs, those kinds of things. It can be really expensive. The Palliative Care Society fundraises for us, provides equipment and supplies in our community, and again, it really impacts the way that we're able to provide care. So they're a very active group. They're active on Facebook and social media, as well as they have a website. They meet monthly. So they're a great organization. And then I would say, one of the best things you can do is kind of start having conversations with your families about, what you want and where to go, especially if you do have a diagnosis that is potentially chronic in nature, but I don't think we talk to each other enough about what we would want if something serious or sudden were to happen, and it's really important because it could happen.
Eventually, it will. I mean,
Yeah.
that's part of what the Death Cafe makes it so special. Is it's bringing.
We
it out.
had her, and twice now.
Yeah.
And we, and that's how I got to know her a little bit. So.
Yeah, it does need to be out in the open. And I mean, I think you hinted at this before. Like, it's not in our culture, Western culture in general. We don't talk about it as much now, maybe as we used to, or in other cultures. Do you find that to be?
I think
a
that we
hindrance?
don't necessarily die the same way that we used to die. We used to be exposed to death and dying from the time we were children, grandparents or great grandparents, aunts and uncles in our home. But we've medicalized end of life quite
Very good point.
significantly,
Yeah.
and part of that is that we are able to keep people alive a lot longer with the advances in medical technology and treatments that we have. But the question is, do you want to be kept alive that way? There's a lot of studies out there that, if you ask physicians, if they had this diagnosis, would you accept that treatment? They would say no, but we're offering those things to people. And because people don't necessarily have the expertise to know what does this mean. Is this intervention actually help me meet my goals or not? They say yes because there's fear and not information provided. And so I think that is the real key point, and why people live longer when a palliative care approach is taken is because not all intervention leads to living longer or quality of life. It can lead to complications and actually a worse quality of life. Sometimes doing nothing is actually the better choice. It helps you live longer with a better quality of life.
Yeah. All good points. Yep. Well, we could probably talk forever, but we've been talking perhaps too long.
I know.
What was the name again of that society? Because people can look this up. It's a local organization.
Yeah. So the Antigonish Palliative Care Society is a great group in town that is doing lots of fundraising, advocacy work. So they're you can find them on.
And Stephen is one of the part of that
You
group
got
as
it.
well. I work with him on the board.
Who's Stephen?
Stephen Eady.
Oh.
Yeah.
Oh, okay. We'll talk
So
more about Stephen.
people in Antigonish might have known about the chicken box fundraiser. So
Oh,
that,
yes, of
that
course.
is the Palliative Care Society.
Oh, yeah, I've done that before. I didn't even realize I was
Yeah.
contributing. I
Yeah,
just wanted some chicken.
We are hoping to have
thank
him.
you.
Yeah.
Well, that worked out great.
Yeah.
And you brought in a bunch of links and resources, so I'll try and put as many of these links as I can in the show notes for today's episode.
Yeah, and I think there's a lot of information out there. There's a ton of resources. So this list is really, if people want to learn more, think a little bit more, they can have a look. I would highlight maybe just a couple. If people, this list has got a few, but one is called the Waiting Room Revolution. I would say that is for people who want to take an active role in their healthcare journey. So it gives you these steps and a way of thinking about, hey, do I have the information that I need to be able to make good decisions for myself when I'm interacting with a healthcare decision? So it's a very empowering kind of idea and process. So that's the Waiting Room Revolution. And then my personal favorite, if after all of this you still don't know what palliative care is, there's a set of videos on YouTube that are done by a physician in the U.S. Called Palliative Care Public Service Announcements, and it just normalizes kind of that approach to palliative care and that it's not a scary thing to kind of be thinking and talking about.
Great. Yeah, and I will have links to all those.
Anything you want to say before we end?
Jamie gets the final word.
Yeah.
Is that what's happening?
Yeah.
Jamie, you're gonna sign out to the whole podcast, so you get to say goodbye to our audience, which you're very excited about.
Thank you for listening. And but I think if you have more questions and like Dr. Rice said, like having these conversations with your family is very important. But if you have more questions too, go to your family provider as well, and talk about these options and if you think it's something that would be right for you. Yeah.
Good last word. Well done.
Thank you for coming in.
Yeah, thank you both for coming in. This
Thanks
is
for having us.
fantastic. See ya.
Thank you for listening to Let's Talk Antigonish. If you like the podcast, don't hesitate to subscribe. Just go to letstalkantigonish.ca and click. Voila! You'll receive new episodes right in your email inbox.
This podcast is a labor of love. Please consider making a contribution, small or large. Maybe a monthly subscription. Depending on the level of public support, we would like to engage local producers and journalists to create more regular deep dive news stories about life here in Antigonish.
Right now, it's just Anuj and I doing this in our free time. You can read all about the podcast and ways to support us at letstalkantigonish.ca. And if you're a local business that wants to sponsor the podcast or even place an audio ad, we are certainly not opposed. A huge thank you to all of our subscribers and especially our paid subscribers, which have helped us to buy the audio equipment that we needed to get this thing off the ground. And remember to get in touch with us if you have an idea for a future episode or a burning question about life in Antigonish that you want us to explore and get answers to. We welcome all feedback. Just email us at letstalkantigonish@gmail.com. Let's talk, Antigonish.